Good morning, everyone. Welcome to this meeting of the Dundee Health and Social Care Partnership Integrated Joint Board meeting. This is my first meeting as chair of this group. So excuse me if I'm not into the Dundee way and I do things differently or in a way that's not the norm, but hopefully we'll manage to get through it together. So please, if I'm doing something wrong, just put your hand up and steer me gently in the right direction. Okay, so this morning we've got the agenda. So Arlene, can I hand over to you for the first item of apologies?
Yep, thank you. Can I just remind everybody that the meeting is being recorded and will be placed on the websites of Dundee City Council and the Health and Social Care Partnership for public viewing. And I'll now do a roll call for the minute. Beth Hamilton.
Present.
Councillor Lynn.
Present.
Councillor Toland. Councillor McHugh.
Present.
Donald McPherson.
Present.
Sam Riddle.
Present.
Diane McCulloch.
Morning, Arlene. Present.
I've got apologies from Vicky Irons. Dave Berry.
Present, Arlene.
David Wilson.
Present, Arlene. Thank you.
Susie Flower.
Present. Good morning.
I've got apologies from James Cotton. Raymond Marshall's hoping to join us later. Jim McFarlane.
I'm here, Arlene.
Christina Cooper.
Present, Arlene.
Liz Goss.
Present.
Martin Sloan.
Present.
Emma Fletcher.
Present. Thanks.
David Shaw. Okay, that concludes the roll call. Item 1 is apologies, which have already been noted. Item 2, declaration of interest. Are there any declarations? No. Okay, thank you. Item 3, joint inspection of adult support and protection in the Dundee Partnership, findings and improvement plans. You're asked to agree the recommendations.
Okay, thank you, Arlene. Elaine, I'm assuming from your presence here that you're going to take us through this report.
Yes.
Right.
Yeah.
Thank you very much.
Yeah.
I'll hand it over to you then. Thanks.
Thank you. Yeah, I just wanted to say a few introductory remarks about the report, and as the independent convener of the Adult Support and Protection Committee here in Dundee. And I think that Diane may have a few comments on the operational elements that she may wish to add following my introductory comments. Just first of all, I would just say there was an Adult Support and Protection National Day on Tuesday, so I don't know whether we had much publicity. We certainly try and raise that with the press every year, and this week there's a lot of activities in Dundee to raise the profile and to help with the learning and development and key issues around staff. And on Friday we have an event when I'm travelling up to Dundee for the day to focus around seeing something, say something, issues around making the public much more aware of adult support and protection and being able to raise issues. So it's quite fortuitous that you're looking at this report this week when there's a huge amount of national interest and also hopefully local interest as well. So that's very positive. In terms of the inspection report, you have a copy in your papers. I would just say that the two areas that they commented on were on key processes and on leadership. And it's reassuring to note that they classified Dundee's work in this area as effective with areas for improvement. So that meant that overall there were clear strengths, supporting positive experiences which outweighed the improvements and looked at outcomes and positive outcomes for people in Dundee City. So I think that's a kind of overall, that's a reassuring conclusion to the inspection. And they also clearly emphasised that people in Dundee were safe, that there was a lot of activity, and certainly the file records overall indicated that they didn't really pick up any concerns in terms of our individual support. So that was all very positive. So just start on a positive note. And there was a lot of other positives in the report about case conferences, involvement of adults at risk in our committee. So quite a number of very key strengths there that are outlined in the report. However, these reports are also quite useful to identify improvement areas. And I think before we started on the inspection process, we were asked to submit a self-evaluation report, which I'm very pleased to say really emphasised all the areas for improvement that I think the inspectors also picked up. So as a partnership, I think we're very aware of the areas we're doing well and areas that we need to improve on. And I think that's the national picture. I can't say any area has got all of this right. There's areas that people need to continue to develop overall. And I think one of our key priorities in the improvement plan is around our redesign of the multi-agency pathway for adults at risk, how we actually manage together health, social care, police, all our key partners, to think about the pathway and the processes as part of that, because that's very much picked up in some of the report around work on chronologies and risk assessments, which we are on an upward trajectory around that. We've got key processes in place, but we know we've got further work to do, and that's emphasised in the report. The improvement plan that you have before you, we have tried to keep quite strategic. There's more detail in a development plan which sits behind this, which the Adult Support and Protection Committee will be monitoring and will be reporting up to the Chief Officers Group as part of that on a regular basis. And that incorporates other priority areas of learning that and work that we need to do. But the improvement plan, I think, does pick up at all the recommendations in the inspection report and identifies what we aim to be doing about it. It has clear timescales, it has key leads, and we will be reporting back on that. And as the independent chair of the Adult Support and Protection Committee, I'll be making sure that this is regularly looked at the committee, and that we do try to make sure that we stick with the timescales, we increase our pace of change. I think that's one of the recommendations in the report, that we need to keep that momentum behind us, and we need to actually make sure that we deliver on the areas that are highlighted. But overall, I think it's very much a balanced report from the inspectors. It's identifying the clear strengths that we have in the area, and also identifying some of the work that we need to do, which as a quite aware area, I think we were well aware of, and probably beginning to do quite a bit of work in these areas as well. So I think overall, I think the report's pretty clear, and you've got quite a lot of information behind that, and happy to take any questions. But I wonder if Diane wishes to come in, if that's okay, Chair, just to say a few words on the operational part of that. Diane?
Yes, certainly. Thank you, Lane. I mean, as always, Lane's given a really full understanding of everything that's going on in Dundee, and apparently a lot of it's down to our leadership in terms of the work that we do through the Adult Support and Protection Committee, but right across all our services. I guess this is a follow-up report to a previous report which highlighted a number of areas, including things like chronology risk assessments, but also our use of our processes around initial referral discussions and case conferences. And what the report really kind of identified, that we'd managed to get all the systems in place in which to do that, and bearing in mind that when we do inspections, these go back a couple of years in terms of where they draw papers from, so they're not always completely contemporary, but actually what we needed to do was really to shift from a position where staff knew what was needing to be done, we're using that, but where it became almost just second nature in terms of tools and processes. Some of the tools are not quite there yet because we're working with our IT company, and the systems that we're using perhaps don't pull things through. So in terms of IRDs, for example, staff tick a box as to what they want to be included in that IRD, and it pulls it through, but doesn't necessarily order it in a way that might make misleading if you were doing it in a different way. We had evidence and started at the beginning with our IRD introductions and our risk assessment introduction. By doing that, only focused on certain areas. We've now rolled that out right across the board, so it's starting to become much more about internal practice, and it's very much about a culture shift. I think probably what I was most pleased about, and actually the inspectors commented that compared with others when they were looking for evidence of concerns across adult sport and protection, we only had a couple of things raised with us, and those things were really just to clarify information and seek just an understanding of things. None of those things were raised because they had a concern, and they commented that that actually was quite unusual in terms of, and something to be pleased about. We have shifted our processes, but perhaps in shifting those processes, we perhaps went too far in one direction, because we were sorry, that's the wrong words. We were advised at the last inspection that we probably focused at an earlier point of the process and not far enough down the line. And I think what staff have made a decision to do is to make sure that we're dealing with that. We probably had, not wrongly, but quite a large number of case conferencing compared with other areas in terms of the way that we were working. So we want to go back and look at that. And we want to just make sure that our systems really support staff in terms of going forward. So a lot of confidence around what was being done. As always, there are issues about processes, but as Elaine said, some of the things like chronologies have been worked on for 20, 30 years. As long as I've been in social work, it's been a concern, and we know that some of the big national organisations are trying to develop new guidance in order to support and help people, but there's something about us getting that embedded. I think the last thing to say is that people like Catherine, as part of the public protection team, and her team are helping us work through a lot of information about how we actually receive people into the service, and we've had to recognise over the last probably 4, 5, 6 months that actually the systems that we had in place in order to receive concerns and referrals into the social work department needed to significantly shift and change. And we did try a test which really just highlighted to us, just in terms of our resources, that we didn't have that right. So we're in a very interim stage of trying to manage things in a slightly different way while we build up the resources we need in order to implement a new pathway and actually work with the staff to do that. And we have a session in March, which is bringing a lot of people together to start to explore some of those issues in terms of how we work across peace and partnership, but equally, what do we think the model should look like going forward, and therefore what do we need to put in place in order to deliver that. So we're in a bit of a hybrid position at the moment, dealing with what we can, just because of the capacity and the changing profile, the way people come into the department, into the partnership, in order to work through how we're going to deliver that going forward. And we need to take a wee bit of time to make sure we get that right this time, but absolutely moving on as quickly as possible. So I'll leave it at that, and like Elaine, happy to take any questions, and lots of colleagues on the call who could also help.
Thank you, both of you. Can I just start? I mean, Jim McFarlane, he had originally had his hand up, but it's gone down, Jim? No.
Yeah, sorry, that was an error on my part.
Oh, that's
sorry,
okay.
just too
Okay.
keen.
Yeah.
So the first person I've got is Dorothy. Dorothy McHugh. Dorothy, would you like to come in?
Yes, thanks, Beth. I've got a couple of comments and one question. It was reassuring, I think, that the position statement aligned quite well with the inspection report. And I particularly noticed it's good to see that the voice of lived experience is evident on the committee. That's good. That's just how it should be. My question relates to 4.5.2 in the report, page 3 of my bundle, where it says investigatory powers were almost always undertaken or overseen by a council officer. Almost always. If not by a council officer, who would oversee this?
Do you want me to come in? Will I come in from there? So a council officer is deemed in statute, Dorothy. So that can include social workers. People have to undertake particular training in order to do that, and they also have to be employed within adult services within a particular period of time. So it's quite a misleading term as in council officer when we talk about councils being Dundee City Council, Angus Council, etc. It's to do with a role. What that would mean is that there are areas where we have integrated teams, and there are times when we've had managers who are not social work managers of other people undertaking those, but they're the manager of that service. So there's a lot of work again going on nationally about what we describe as second officers when it comes to inspections, which might mean they are not council officers, but also how we ensure that supervisory arrangement is in place. So it's sometimes to do with management structure. It's also something to do with the people who are actually undertaking the investigation at the first place. But for Dundee, high level is done by council officers.
So it would always be, Diane, a relevant and a qualified person.
Yes.
Right. Okay.
Yes.
Thank you.
Just to add to that, the difference between Dundee and other areas, so all of our social workers are council officers who work in adult services. In other areas, they might have a dedicated team.
Okay, thank you, Diane. Dorothy, you quite happy with that? Okay, thank you. We'll move on to Ken. Kenlon, please.
Yeah, thank you, Beth, and welcome to your new position as chair.
Thank you.
Yeah, I'm pleased with this report. It says effective with room for improvement, and I think there's probably room for improvement in every sphere of activity we undertake. I'm just wanting to ask a question around 4.6.3, where it says, I don't really want to read it all out. 3 of the 6 areas for improvement relate to strategic leadership and oversight of improvement, etc. And then at the end of 4.6.3, it goes on to say that steps are being taken to ensure that sufficient resource is in place to actively support the implementation of the improvement plan. Just like a little bit more detail about what these steps are, please.
Diane, is that something you could pick up?
I think Catherine was about to come in.
Oh, good stuff, Catherine.
Thanks, Ken. There's a little bit of detail in the improvement plan, but I'll speak just about some of the key things. So there are some things around particular posts. So for the Adult Protection Committee, we're just in the final stages of recruiting permanently to the lead officer post that holds the remit around the Adult Protection Committee. But there are also posts in health and social care as part of Diane's structure that she might want to comment on, who have some operational leadership roles, so making sure that those are filled. We're also working with partners to identify some additional resource subject to the budget setting process to be able to secure some additional temporary capacity to focus on the development and implementation of the new adults at risk pathway, which will be really critical. But we are very clear that that pathway cannot be designed and implemented by one person alone, that needs to be worked on, particularly with the workforce who are involved in adult protection activity day to day. So there's particular things about some additional capacity, and we've also got identified some short-term additional capacity within health and social care, just to finish some of the things that have been started but just need to get over the line in terms of procedures, routine case file auditing within health and social care, and some work about lived experience feedback and capturing that. So there's bits of new resource, but there's also a discussion to be had actually tomorrow at the Chief Officers Group around how leaders support staff across the workforce, relevant staff across the workforce, to have adult protection. Some of the improvement work is more a priority within their existing workload, and we know there are pressures across teams, but in terms of implementing some of the quality assurance work and some of the changes in practice, that will require staff to be involved in some of those kind of developmental discussions, but also training activity, etc. So there's a focus on also how we can prioritise that within the kind of and support staff within the time that they've got available to them as well. So a bit of both sides. The Adult Protection Committee has just approved a action plan for its self-evaluation and continuous improvement group, which will help us to evidence the impact of the changes and setting in place a clear reporting schedule between the committee and the COG, and then back back to IJB Council Committee, NHS Tayside Board as well, so making sure that's a little bit more robust and transparent in the future as well, Ken. So Elaine, I don't know if there's anything you would want to add to that as the chair, but those are the kind of things around resources and reporting.
No, the only thing I would add is absolutely any additional resources to help us take this forward. But just to emphasise that point that Catherine made, it is about leadership. It's about all staff engaging with this, because what we need is a culture shift here and a lot of change in culture, and people understanding that whatever they do, it's got to be on a consistent basis and not seen as a little project sitting over here where people kind of think it belongs to somebody else. So I think, yeah, any additional resource is very welcome, but we do have that leadership role, I think, in terms of explaining to staff what the changes are, engaging them in that, and helping them to deliver those along with the leaders. So a bit of work to do around that whole change. But no, that's fine. Thanks, Catherine, for that.
Chair, might I just add a comment, please?
Yep, of course, go for it, Ken.
I think the point about people with lived experience is really important. I visited Hope Point, the new 24-hour mental health crisis centre, yesterday for the first time since it opened. My previous visit was prior to the opening, and met a number of the staff, many of whom had lived experience of mental health or distress themselves. I was really impressed with how they were using their experience, their adverse experiences, in a positive way to help others. So I'm pleased to see that that's also the case with adult support and protection, that we're using people with lived experience. Thank you.
That's great, Ken. Thanks. I've heard a lot of good things about Hope House. I'm hoping to get over to meet the staff and see the place myself soon.
Oh, you should do, Beth. It was fantastic.
Yeah. Great. Okay. Donald, do you want to come in?
Thanks very much, Beth, and just add my welcome to Ken's in your new role as chair on this board.
Thank you.
Also, thanks to Elaine and for their helpful summaries of the report. And I think there's a lot in the report that we can take comfort and be assured by. Just a couple of points, if I could, on specific points that I think stood out to me as I was reading the full report. The first one was there was a comment around the lack of general practitioner engagement in the processes. And I was just wondering, do we understand why that is, and how are we going to be able to address that? Because clearly they're an important part of the whole environment here. The second point was, again, I suppose I was a little bit surprised to see that advocacy, independent advocacy, was only offered to around half of the people who might have benefited from it. And again, it's something, we hear a lot that people feel that things are done to them without their active engagement, and advocacy can really help to ensure that they have a voice. So I just wonder why that wasn't happening in such a large proportion of the cases where they would have benefited. And so again, what are we going to do about it? I think on one hand, in the position statement, it's reassuring to see that matching between what we knew ourselves and what we were told by the Care Inspectorate. It's always nice not to get any unpleasant surprises, but I suppose the other way of looking at that is, if we knew about it already, what was it stopping us making changes on our own account rather than waiting for someone else to tell us? And again, just linked to that point and thinking of the financial pressures that we're going to be under as we move into the coming year, what are the financial implications of doing this action plan, which we must do? What are the financial implications of that, and how does that affect the work that Dave Berry is doing around financial planning? So there's quite a mixed bit in there and you maybe want to divide things out amongst yourselves.
Okay. Shall I perhaps kick off with some of those, and then other folks can, other officers can come in. So the first one about the lack of the GP in the process, I think on the committee particularly, we have had an issue. We've had an interested GP, but our committee meetings were on a Monday afternoon and he just couldn't come. So he sent apologies, but he certainly got all the papers and he certainly asked questions and took an interest. We've now changed the committee so that we're now on a Tuesday afternoon, and I'm happy to report that the GP representation has now restarted. So I think it wasn't a lack of commitment; it was just an issue that we had scheduled the meetings for that afternoon, which wasn't suitable. So I'm hoping we've addressed the committee representation. There's a broader issue around making sure that GPs are engaged in case conferences and things, and I think that's kind of been, that will help by having a committee member and reporting in. And I know we've been trying to get to the GP subcommittees and things like that to raise the whole issue of adult support and protection. Grace has been doing a bit of work around some of that, Grace Gilling. So yeah, quite a bit of work, but I'm hoping the committee element has been resolved, Donald, as part of that. The issue of what, if we knew about it, what we were doing about it. Yeah, I think that is an interesting one. Some of the areas of work we started doing as a public protection arrangement, and we started in child protection, and we were rolling out the learning to adult protection. So in some areas we were working on it, but we weren't quite embedding it yet into adult support and protection. But certainly there was a lot of work going on to address that. So, for example, in terms of chronologies and risk assessments, there's been a huge amount of work embedding that into the system, as Diane explained before. The next stage is to make sure that staff are well briefed on it and there's a consistency of usage. So I don't think it's people being complacent at all. I think there was work going on, but I think we just need to make sure that we don't take our eye off the ball, and we progress that in a timely way. So I picked up a couple of points there, but perhaps some of my colleagues, Catherine has got a hand up and wishes to come in on some of the other points.
Yeah, thanks, Elaine. Just to say, and I know Elaine's updated around the GP engagement at committee level, but also to say that I have had some recent discussions with the GP rep on the committee as well about that operational link to primary care and how primary care can have a role in the development of the new adult at risk pathway. But they need to recognise it isn't just about GP, it's about primary care and the whole practice and the whole range of expertise there that might be able to contribute. So, but they're keen to be involved in that. So I think that's helpful. Around advocacy, I think there's a bit of a multifaceted kind of issue around about that. I think there are issues about our recording of offers of advocacy, and we have a very clear action on the Adult Protection Committee's delivery plan to improve our recording around who is offered, when people refuse, why it is that they refuse, etc. So we have a better understanding about what the issue is, because I'm not convinced that at the moment, Donald, we definitely know there is an issue, but we're not completely clear about what that issue is. So there's advocacy and also representation through others, including carers and family members, and we want to better understand that whole picture to be able to look at it. But we also do think there are challenges around training and understanding of the very specific and unique role of independent advocacy. That's also a challenge in children's services, so we'll probably do some joint work with them round about that. Although what I would say was pleased to see the inspection report acknowledged that where advocacy was available, it was very positive for everybody involved. So we obviously want to see more of that. In terms of the position statement and the matching and the kind of progress bit, I think it is maybe interesting just to highlight that, and you'll see in the position statement there were a number of key areas that appeared in both the strengths and the areas for improvement list, and I think that probably reflects the fact that we have been doing some work, but we've got more to do, and the report talks about that, and Diane said that about the 2017 part of it. So I think it's clear both from the report and the position statement that none of these issues were things that we knew about and had done nothing about. I think they had all been in progress, and that's reflected in the delivery plan too. And on the financial side of things, the additional posts and capacity that I spoke about earlier are all reflected within the kind of current budget proposals. So we have, confidence around the availability of the funds around that. But I'll bring Dave in for anything he wants to see more broadly about the kind of adult protection aspects in the budget process.
Yeah, thanks, Catherine. Yeah, just going to pick up on that. So just to confirm, in terms of our kind of structure, discussions that we've had, what we've done is kind of we're looking at sort of reprioritising some of our kind of existing resource within the sort of adult protection kind of side of things. I think most of the other issues that have been raised in terms of sort of kind of developments and must-dos are really about sort of the system changes, etc., and are not at this stage requiring anything significantly in terms of additional investment. But if there is anything that we can, as we kind of work through that we think we need in terms of additional investment, then we will initially kind of look at the resources that we've got, again, back to kind of reprioritising what we're doing. And if there is an ask as a result, if there's a kind of residual ask for resource at the end of that, then we'll come back and report back to the IJB around what that ask might be. Some of it might be kind of short term, some of it might be kind of longer term investment. So we would, but in terms of that, no, there's nothing additional from what we've got at the moment in terms of our budget for next year around that.
Okay, no, thanks for all of these. Now, I think the only point to just come back on is that advocacy one, and Catherine, your explanations is helpful, but we've got some excellent independent advocacy services, and we should recognise the value of it. So thanks very much. Thank you.
Okay, thank you, Donald. Sam, would you like to come in now?
Oh, good morning, Beth. Welcome to Dundee. Good
Thank
luck
you.
for your yes. In fact, my question, Donald has stole my thunder, because like Donald, I'd read the report in full, and I was querying what progress has been made with the lack of engagement of GPs, but that has been answered. So thank you, and I'm reassured that things are moving forward. Thank you.
Great, thanks, Sam. Liz, would you like to come in?
Hi, I just wanted to echo what others have said about how pleasant it was to see that an adult with lived experience is a core member of the Adult Protection Committee, and also that they are valued and supported to provide a meaningful input, which I think is really important as well, and not something we always get right, and perhaps other services could learn from what you guys have done. So that was my only comment. Thank you.
Thank you, Liz. Siobhan.
Thank you. I think it's a really, really positive report. A couple of kind of major positives, I think, for me, is the level of self-awareness and self-analysis. I think that showed, that self-report showed that you were absolutely in tune, I think, with the external report. So moving forward, I think that's a great kind of way forward. I also picked up quite a lot of, and I'm looking at 4.55 in particular, it says that, there were some issues in the 2017 inspection, but these areas were, in terms of case conferences, as an example, completely turned around. There was language like innovative, I can't remember the other positive one that I picked up on. So it's actually really, really positive report, I think. One question, maybe just more clarification for me though, was the issue of the risk assessments, and that was one in the area of improvement. I'm just wanting to kind of be clear that I've kind of got this understanding right. It seemed to be that there was a lack of maybe alignment and consistency in terms of risk assessments and how that's done across the multi-agencies and so forth. And obviously there's moves to kind of resolve some of those issues. So you can maybe just expand a wee bit on what that actually meant and how that influences perhaps the kind of how you assess and how you move forward and take those cases forward.
Diane,
Right,
do you
okay, Diane.
Yeah, I'm happy to come in to do that. So one of the things that we did after the 2017 inspection was actually to work with the Care Inspectorate in order to develop a number of areas of work. And that's one of the reasons why, for example, we started the work around chronologies in children's services, because a team in children's services were brought together to develop what it should look like, what guidance should look like, how that should be done, etc. And one of our teams, learning disability team, actually pulled together the work around the risk assessment. So they worked with the Care Inspectorate to identify what that should look like, how that should function. We tested that across other areas. We then had it installed into our systems in order to be able to do that work. I think there was kind of two issues. One is about consistent use of that. And sometimes when something is developed in an area, other people feel that for different, sorry, I think I might, no, I'm not. I think it's the one that's frozen. You're back again. That's it. I think it's just stuttering. Sorry, I wasn't sure if it was you or me because I was looking at you when I was speaking, Siobhan. So yeah, so there's something about us making sure that that is absolutely fit for purpose for every scenario in terms of the work developed in a specific area, rolled out, just embedding, ensuring that's resolved. But the other aspect around risk assessment, and this is one perhaps that you're not picking up, is worth mentioning, is that we do an awful lot of work around what we call core group work, which is around looking at risk management. So for many people that we work with, that risk remains and is ongoing because of either the lifestyles that they lead, the kind of conditions that they have that might present risk to themselves or others. So we do an awful lot of work which is about ongoing risk management, which doesn't always bring it back into adult protection, but is managed through a core management risk assessment. And you've all frozen, so I don't know if you hear me or not, but I'll keep talking. And that was something they felt maybe needed to be pulled better and back into the adult support and protection process. Can I just check if people can hear me?
Yeah, we can.
We can.
Okay, my screen's completely frozen, so I wasn't sure if you were. So there is something about us looking at that pathway, Siobhan, to make sure that we're kind of embedding the risk assessment consistently across the piece, that we're doing that risk management and that's clear and linked back to our adult protection work, and that we've got good understanding of why we might manage it in one way as opposed to the other. Hopefully that's fine.
Thank you, Diane. That's great. I heard every word.
Diane, could I just come in and say that it is probably worth saying that the report does say that risk is being managed effectively. So perhaps, and often managed by case conferences, but perhaps as Diane's alluding to there, it's the way we're recording it needs to be much more thorough and effective. So I think there wasn't any concerns about the actual risk. We were managing it, but the way we're documenting and recording needed to be improved. So just to reassure you, Siobhan, about that point as well.
That was clear in the report, Elaine and Diane. I was clear on that. I was just unclear about the nature of what the risk assessment involved. No, I think that was clear, and I think that there was good evidence throughout the report that actually the management of risk, the physical, kind of nitty-gritty management was actually very good.
Yeah, thanks.
Okay, thank you, Siobhan. And I think lastly we've got Christina. Christina, do you want to come in?
Yeah, thank you. Nice to see you, Beth, again.
You too, Christina.
Good to see you. And thanks, Elaine and Diane, for that update. I think it's a very well balanced report. Just to come back on Donald's point in relation to, professional independent advocacy, and to give you some assurance that across the partnership in Dundee, there's been a significant investment from the Whole Family Wellbeing Fund to Dundee Independent Advocacy that's going to be supported from the third sector interface as well, looking at a strategy for the city so that harnesses all the existing professional and other types of advocacy in the city, looking at gaps and strengthening, a work plan to integrate the services. So I hope that provides some assurance, and there's also investment in areas such as authentic voices, so people do have a voice across all of the strategic areas and critical committees in the city. So we can keep you updated in the progress in relation to independent advocacy, but it's a good news story for Dundee, and I think it's going to be very much well received for all of the services, children and families and adults moving forward.
That's great, Christina, thank you. Okay, I think that's all the questions. It's obviously a mixed bag, but on the whole a good report, and it's really good to see the whole protection agenda moving forward as much as it has. I've noticed a huge change across services since in the last 10 years, so I'm really pleased to see that in Dundee as well. Okay, now I'm just going to ask Arlene, usually what I would do at this point is read out the recommendations myself. Is that appropriate, or do you do that, or?
No,
Do we
it's
not need-
appropriate for you to do, Beth.
Okay, thank
Thanks.
you. So for us, it's recommended that the Integration Joint Board note the content of the inspection report published by the Care Inspectorate, note the summary of inspection findings, including areas of strength and areas for improvement, note the multi-agency approach to improvement planning that has been progressed since receipt of inspection findings and the improvement plan approved by the Dundee Chief Officers Group and submitted to the Care Inspectorate on 7th of February 24, and instruct the Chief Officer to make arrangements for a further update on implementation and impact of improvement plans to be provided to the IJB in line with the schedule of reporting between the Adult Support and Protection Committee and the Chief Officers Group. Are we all happy with these recommendations? Brilliant. Okay, thank you very much, folks. Arlene, I'll hand back to you.
Thanks, Beth. That takes us on to item 4, minutes of previous meetings. The minutes of the meeting of the 13th of December and the 31st of January are submitted for approval, and the action tracker is submitted for noting.
Okay, thank you very much. Do we need a proposer and a seconder for these? Can we have a proposer?
Happy to propose, Chair.
That's Ken's proposing. Sam, you seconding?
Mhm.
Okay, thank you very much. Okay, that takes us on to the next item, Arlene.
Beth, we would usually see if there were any comments about the action
Right,
tracker. Okay.
Okay, sorry. Action tracker, any comments? Any clarity required? Dorothy?
Thank you. Yes, I did have a comment on the action tracker. Number 10, just a wee update. The chair would arrange a discussion with councillors Lynn and McHugh about integrated impact assessments. And I have had a very helpful discussion with Catherine around my concerns about the integrated impact assessments. Ken, you weren't at the meeting. I'm not sure if that, you know, if you really had wanted to be there, or you were just facilitating me with my queries. But I've had a very helpful
I had a period
meeting.
of sickness, Dorothy.
Oh, sorry, Ken.
So no problem.
I had a very helpful meeting with Catherine, and she has assured me on a number of areas that I had concerns about with the integrated impact assessments. So thank you, Catherine.
Thank you, Dorothy. Liz?
Yeah, just for my information, I can see that quite a few dates have been changed to June 2024. And I suppose I just wondered how confident people were that those dates will be met when previous ones haven't been.
Mm-hmm.
Good point.
I'm happy
Okay.
to come in on that, Chair, if that's
Right,
okay.
Diane, thank you.
Yeah, so this relates, a lot of this relates, in fact, nearly all of the first ones relate to the mental health strategy and the learning disability strategy, sorry, that we had in place. A lot of our effort has been focused on what's been going on in relation to the Teesside-wide approach to learning disability. So Ali Mitchell, who's our manager, was actually trying to lead the Teesside work stream in terms of that work, and we kind of felt that might be relevant in terms of where we went with the next stage of our strategy. We've actually made the decision in relation to this outstanding piece of work that Arlene's actually going to be stepping back from a bit of that Teesside work just because of other reasons, but we're actually going to focus on getting this done. So I'm hopeful there's a draft coming to me quite soon in relation to that, with a view to it coming back to this group in June. So relatively confident this time.
Thank you, Diane. Liz, are you happy with that? Okay, thank you. Dave, do you want to come in?
Yeah, no, it was just to kind of follow up, so it's not all just about kind of the actions that are set with the kind of learning disability strategy, because I know there's a couple of others. So we have, I think we kind of talked about last time, Beth, appreciate you wouldn't be there, but around sort of development sessions, and we had kind of planned to kind of factor some further development sessions on the first quarter, and just unfortunately because of kind of staffing issues at kind of leadership level, we've kind of had to kind of rearrange things at the moment. So we will kind of still kind of remain focused on getting those development sessions in, but they'll probably be kind of not the kind of first quarter of this year, but start to kind of drift into the second quarter. So, so that's why we've kind of put some of those back to kind of June as well in terms of those responses. So, and it really is kind of being a bit more realistic about when we think we can deliver things.
Okay, thanks. Just for clarity, and you're talking about quarters, first quarter, second quarter. You're talking about calendar years there.
Yes, calendar year in this
Just
instance.
as soon as I see your
usually
face,
talk
Dave,
about
I
financial
automatically
years.
go into financial years. But no, that's fine. Okay, thanks for that. Any other points or any comments or clarity required in the action tracker? Okay. Right, thank you for that. We'll move on. Arlene, can you take us on to the next one, please?
Yep, that takes us on to item 5, the Performance and Audit Committee. The minute of the meeting of the 31st of January and the Chair's Assurance Report are submitted for information and record purposes.
Okay, is there any thoughts? Do we need to take a proposer or seconder for this one if it's not our minute? Nope, good stuff, just double checking. Anything else we normally look at the Chair's Assurance Report or anything? Dorothy, would you like to come in?
This is just a question that I should probably know the answer to. We have an action tracker with the IJ board minutes. We don't have an action tracker for the PAC. Is that just how it works?
Okay,
We do. So sorry, we do have the action tracker for the PAC, Dorothy, but that's not shared with the IJB. That remains the kind of Performance and Audit Committee's responsibility. So at each meeting of the PAC, there is a similar action tracker to the same one as the IJB on issues that arise from the PAC.
I should know that because I'm probably one of the people that always has a question on the action tracker. Okay, but it's not shared at this meeting. Okay, thank you.
Okay, thank you for that, both Dave and Dorothy. Donald, do you want to come in?
No, I was just going to say, since I chaired that last meeting in Ken's absence, that yes, we did have a good look at the action tracker for PAC actions, and just that there were still quite a few older actions there that we were asking management if some progress could be made on those. And we did also review the terms of reference of the committee, just to reflect, I think, the discussion that we had at the previous IJB around changes to the terms of reference. So that was all I was going to add. Thanks.
Thank you, Donald. Dave?
Thanks, Beth. I'd just like to kind of put on record and thanks to Donald for stepping in to kind of chair the meeting on the day. So kind of grateful for you doing that.
He's a good lad. He's a good lad, is Donald. Thanks, Donald. Okay, anything else about the Chair's Assurance Report or anything we want to clarify? No, all happy? Great stuff. We'll move on, Arlene.
That's item 6, membership of Dundee City Health and Social Care Integration Joint Board, Chief Social Work Officer, and you're asked to note the position.
Okay, is everybody clear on the position? Do I need to read that out just to confirm that Diane McCulloch will be retiring? Diane will be retiring from the position of Chief Social Work Officer, and Glyn Lloyd, Head of Children, Family, Social Work and Community Justice, will cover all Chief Social Work Officer functions effective from 1st of March and replace Diane as a member of the Integration Joint Board from that date. Diane, I wasn't aware this was going to be your last meeting.
I could maybe clarify, it wouldn't be my last meeting. So
Right,
as part of our, so please don't rush in with lots of plaudits and thanks because I'll stop you here the next time you meet.
Right.
The Chief Social Work Officer is a statutory role that sits as a member on the committee and on the board, whereas the Head of Service is an officer role and is not a member of the board. So we are transitioning the Chief Social Work Officer a few weeks before I retire in order to allow that transition to happen and everything to be put in place before I actually kind of sign off. So Glyn will come in as a member as Chief Social Work Officer, but I'll continue to attend as an officer for the next kind of couple of months.
Great. Oh, phew. Okay, thanks for that. Thanks for that clarity. And we'll welcome Glyn. Ken, want to come in?
Excuse me. I was about to pay fulsome tribute to you, Diane, but that can wait. I may not be conservative in my politics, but when it comes to change, and that change involves the retirement of a really valued member of staff, I am very conservative with a small c, but I'll have more to say at a later date. Thank you.
Oh, you've got time to write your speech, Ken, and get all the right points in. Okay, thank you for that. Sorry, Diane, we all had a wee bit of a shock there. Thanks very much for that. Okay, can we move on then, Arlene?
Okay, that takes us on to item 7, full service, and this report is for noting.
Okay, are we going to go through this? Is there somebody taking us through it? Oh, Matthew, you've popped up there. I'm guessing it's you. Okay, I'll hand over to you, Matthew. Thank you.
So I've just got a few key points really just to raise to the committee's attention, and then be happy to take any questions. So obviously you've got the full report, you'll have read that through. The headline figure does continue to remain a challenge in terms of people aged 65 and over who are admitted to hospital as a result of a fall. We continue to be challenged across Scotland in terms of being the worst performing partnership with that, but we do think that there are reasons and mitigations for that. The number of falls that we're seeing is staying, it's increasing, but it's not increasing at the same rate as the rate. And we're starting to see, for example, the Perth partnership starting to have an increasing number of falls there. That's probably due to the lower rate of population for the number of people that are aged sort of 65 or over in Dundee as opposed to Perth. I wanted to sort of make a point about the significant positive contribution that all of our partners are making across the pathway. It's a multi-professional, multi-agency approach that we're taking to try and address falls. And it's not just a medical or a clinical or a health model. It's, as you can see, it's section 7.2 in the report. There are a very, very wide number of people that contribute to this. And we're getting really, really positive feedback coming back in from patients about the impact that the input that we're providing is having, about how we're able to support people to be independent, to be returning to the activities that they want to do, and contribute into society and lead the lives that they want to. Very simple things like returning to line dancing. We had a great report for somebody that was really keen and not able to do that, and through the work that was done, that sent a video in of them doing that. So it's fairly small, but it's really, really positive. But also the social isolation that can result in and around issues with falls. But a lot of services are doing significant work to help people with that as well. We're also measuring the impact that we've got from a more clinical perspective as well, and some of our very specific clinical outcome measures are showing that when we have the opportunity to work closely with people, we are having a very positive impact. I know that we've spoken in the past about the numbers going through to the emergency department and how a lot of them don't stay very long, i.e. less than 2 days, and a significant number don't have any procedure undertaken. The figures in the report quoted 53% stay for 2 days or less, and 67% have no procedure undertaken. We are now working through the framework that's been developed and that's been shared with you much more collaboratively with our colleagues across the other health and social care partnerships, but also acute, and with the emergency department specifically and the Scottish Ambulance Service. And I think this is important because a lot of the changes that we need to make really do need to be made on a fairly system-wide basis, particularly for the SAS. And the way that they're configured and set up, they operate on a national basis. So for us to make changes in Dundee is very difficult for them to implement. If we can do that at scale, we've got more chance of having more success as we move forward. The early data that we're gathering through the framework and the subgroups that we've got starting to break down for us a little bit in terms of understanding a bit more the SAS contribution across the pathway and the emergency department contribution across the pathway. And some of those figures, the 53% and 67% that we talked about, I actually see as a positive thing. I think by taking people into the hospital, we're looking after them, we're supporting them, and then we're returning them to their home the following day with the opportunity of putting support in place for them, rather than returning them at 10, 11 o'clock at night or through the night to a cold and empty house, where they might still be feeling quite anxious and afraid as a result of the fall that they've had. I've mentioned on page 4 of my report, sorry, I've just got my report open there, but the life curve model, which I'm not going to talk a lot about, but I'm happy to expand onto that if it would be useful for the board to hear anything about that. It's essentially a model that looks at functional decline And on the left-hand side of the model are a list of 15 different functional tasks. And the research shows us that people lose the ability to perform those tasks as they age. And the research is fairly reliable in the order that they come through. There are a few tasks that sit above that before you come onto the life curve. Things like walking a mile, being able to get up off the floor, brisk walking, and hiking. People can move up and down these curves. And I think as a model, and the way that we've described it through our Falls group, it helps clinicians, but also our partners and those that are volunteering, those that don't have clinical backgrounds, in understanding how they can support people to remain independent and functional for longer, or how they can return to independence or function if they've had some sort of life event. The average age for coming onto the life curve, so this is for people that are struggling to or are able to cut their toenails, is 45, which is young. And I think in Dundee, although I don't have the figures for this, because of our deprived communities and because of our lower educational attainment, entrance to the life curve is probably lower than that. So that poses problems for us in terms of supporting people over the long term. The choices that we make can absolutely support the position that we might hold on that life curve. And there's a statement that I put into the paper based on some research by various authors, that 25% of how we age is genetic and 75% of how we age is about the choices that we can and do make, which is quite a striking figure. So I'll come back to the life curve if people would like me to, but I won't say any more on that for the moment. The last thing I want to say really is about how we perhaps market and talk about falls. This paper's on here as a falls paper and falls strategy. People, I don't think, like talking about falls. We do have a problem with people wanting to and consenting to be referred through to a full service. The ambulance service, the emergency department, our own social care response service have a lot of people that don't want to be referred through to a full service. And indeed, some people that have will say, but I didn't fall, I slipped or I tripped. And they don't identify that they've had a fall. So I think that public health work that we need to do in terms of supporting people and then how we provide the support and get people in front of the right people is really important. I know that our Falls lead in Dundee last week and this week is engaging with some pensioners forums and other forums about how they want to receive information, how they want us to talk about falls, how they want us to engage sort of the best with them to get the best out of them. So while the headline figure remains a challenge and a problem, I'm very confident we've got lots of very, very positive work ongoing. When we get the opportunity to work with people, the evidence is telling us that we're doing a really good job. The sharing of the life curve model for patients as well as those that are supporting them, I think has been really positive in terms of helping people think about their health in a different way and what they can do to remain independent for as long as possible. So I will pause there, but happy to take any questions or comments.
Thank you, Matthew. That was quite comprehensive. Can I take Chair's prerogative and ask the first question? You were mentioned, I noticed that we were the highest falls. Now, has this been consistent or is this a change from previous years? I mean, are we increasing out of that as an outlier or are we always an outlier?
We've been consistent for quite some time, Beth, and it's made us sort of look a lot at the data and the pathway that we've got. And we do wonder, and this is why the work with ED is really important. We've started it, but getting into the detail of their data, I think, is crucial here. A lot of people go to 9 wells and they're admitted, but nothing's done with them. And I think that's to support them, you know, social admissions to support people. And it is done in other areas, but not to the same degree that it's done within 9 wells. There might be other contributory factors within that. The Scottish Ambulance Service at the moment are looking at, for example, are there decisions that are taken by the crew influenced by how long people might wait to get into ED? And of course, we've got the best performing ED in Scotland, in Dundee. So there might be other factors that contribute that, but we're collecting the data to try and understand that fully. But no, sadly, Beth, we've been like that for some time.
Okay, thank you for that clarity, Matthew. Donald, do you want to come in?
Yeah, thanks, Beth, and thanks, Matthew, for bringing this report Firstly, thank you for explaining the life curve, because I hadn't got my mind round it at all, but I see now what it's trying to tell us. I mean, I suppose, like Beth, this point, there's a lot of data in the paper, but I'm not sure I feel any nearer to knowing why there's that variation between Dundee folk and the rest of Scotland, and it would be really helpful to, rather than necessarily mining more and more data, just starting to think about those questions. And I was pleased to hear that that's something you're talking about just trying to understand, and if it is actually because a pathway that works better for the people of Dundee, and that they get this holistic health check when they come in, then let's understand that and let's acknowledge it. But at the moment, I still don't feel we're clear enough on that. And the other point, and it's helpful to read about the Falls group. I think the thing that struck me when I looked at it is that's an awful lot of people who are having to get around a table, and it's taking a lot of time, I'm sure, in the way that multidisciplinary team meetings like this often do. And my question is, are we clear enough on what are the outcomes and what will be the measures of success of the Falls group, and when might it move into something different? Because sometimes a group like that has a tendency to just keep going on and on forever and not really to evolve. So it's a bit like these short life working groups that never seem to be very short. So I just wonder, have you thought about the future development and setting of outcomes for the Falls group? So thank you.
So Matthew, if you want to come in, but can I just check, Emma, are you wanting to come in about this question? I'll bring you in after Matthew.
Yeah, I can comment on the data if that's helpful.
Okay, Matthew, do you want to go first?
Okay, thank you. Yeah, I completely agree with your first point, and bringing ED in to help sort of understand and acknowledge where we are will be really useful. So hopefully we'll have that fairly soon and be able to sort of share something a bit more comprehensive. In terms of the Falls group, I think one of the key successes for the Falls group is the networking ability that we've got, and the ability for us to make sure that we can support our patients in the best way possible and get the right people to support them at the right time. So the way that we refer patients between the different services and make sure they've got the right people to support them has been really successful. You're right, there are a lot of people there. They don't all attend all of the time, and actually there's a fairly high turnover in some sectors, which means that actually keeping meetings going and educating people is sort of really important. The framework has taken us down a slightly different way for these groups, in that we're doing, rather than all of the Falls group meetings that we currently have within the system, we're having network events and key stakeholder events through the year as well. So we're actually bringing together, it's actually a bigger group, but it's across Tayside, and it includes some of the national groups as well, like SAS. So there's an opportunity to share the learning and grow and develop our understanding of what's happening sort of even further. So I suspect that the group will continue, because it's the people that come seem to value the opportunity to work together, and actually the work that's generated from that in terms of community engagement and helping me as a health clinician thinking differently is really valuable. I don't know if that answers your question fully, Donald.
Yeah, I think it does. Well, the piece is still, I would like to know what it would view as success. In the paper you do talk about some the key aims, but I would always like to know what's the level of reduction we're targeting, what's the improvement that we're looking for, rather than just making them subjective statements. But okay, that's been helpful. Thank you.
Thank you.
Okay, Emma, would you like to come in now on the data? Thank you.
Yeah, that would be helpful. Thank you. And it is brilliant to see this work because, as Matthew has flagged, to have that public health approach, that early intervention, that thinking of upstream intervention is really, really important. And for and also for colleagues to be taking forward the public health approach, it just exemplifies that we don't need to be embedded throughout. But coming back to the data, so falls data, falls hospital admission data it can be quite difficult to compare consistently across the country. Falls are a symptom often of other health conditions that are happening. You can have your mechanical, kind of uncomplicated falls that are just purely a trip. But also we see people presenting with falls for a number of different other medical conditions, be it acute illness, be it stroke, be it challenges in eyesight, changes in medication. So I suspect that what is happening is there's probably a coding element that is being seen in this data. And my reason for thinking about that is that both Angus, Perth and Kinross and Dundee all have higher incidence compared to Scotland. So I wonder if there's a bit of kind of how admissions are being coded that is different to other areas in Scotland. However, that completely doesn't negate, that's a double negative, sorry, but that doesn't, it's absolutely imperative that this work is continuing, because we will see, with an ageing population, increased incidence of falls. It's incredibly welcome that the team are working on this and thinking about upstream interventions. So hopefully that gives a bit of context to the hospital data and some of the limitations around it, but it still absolutely will be able to use to track progress, and provided that there's not a systematic change in how coding occurs within the hospital setting.
Okay, thank you, Emma, for that clarity. Dorothy, do you want to come in?
Yes, thank you. Matthew mentioned engagement, community engagement and outreach, and I'm pleased to say I run a Blethers Cafe for older people at risk of isolation every Thursday, and we've had an approach from the Falls lead to come along and do a session with us. And the Pensioners Forum would be delighted to have such a contact as well. I think that's really important, reaching out to vulnerable groups, and maybe a few hints and some advice about self-help and self-awareness, so that's definitely the way to go. And we're very happy that, I think it's Masha, yes, is coming along to our meeting in March to the Blethers Cafe. I have a question relating to the National Falls and Fracture Prevention Strategy being paused. So I'm assuming that means that's not going to happen now. So good for us that we're putting together a strategic framework. I'm a wee bit unsure about frameworks as opposed to strategies. There seems to be a penchant nowadays for frameworks rather than strategies. I'm not sure why this is. I have a feeling that frameworks don't need to be so directed, and have as many outcomes. And I'm not sure, Matthew, maybe you could help me. What is this move towards frameworks and away from strategies? What's behind that?
So I'm not sure that I can answer that directly. I don't know if other colleagues could specifically. I know that the IJB director who led on the development of the framework was keen to do the framework there. In terms of the work that we're doing and the fact that it actually is linked to the previous strategy that existed, but actually is all still relevant. So we've taken the principles of the strategy and we've really updated them to make sure that from a Tayside perspective, we've got all of the elements to manage falls, and we've refreshed that and brought a new group around the table to do that. But I know that doesn't answer your question in terms of strategy and framework. I don't know, can anybody else help me with that?
Catherine will be able, as a resident expert on strategy and frameworks. Catherine, over to you.
What an introduction, Beth. Well, I don't know. People may not agree with me, but I suppose from a local perspective, because obviously when we last did the IJBs, strategic planning work, we went for a framework rather than a strategy. I guess my general observation was that people tend to use frameworks that sit at a slightly higher level and probably separating out the content that's around vision, direction of travel, priorities and outcomes from some of the more detailed stuff that's around actions and delivery. We've chosen to do that because we wanted to have a direction of travel and vision over a longer period of time. Traditionally, our strategic plans put both things together, and what we found and have learned over a number of years is that it was difficult to write actions that far in advance. So if you sit at the start of a 3 or 5 year period and write lots of actions down, they very quickly don't become the wrong actions because the world moves around you and those sorts of things. So I think we've done it to try to separate out an overall strategic vision and direction of travel and have a consistent longer term approach to that, and then use the flexibility of kind of action plans, delivery plans to have the right set of operational actions on an ongoing basis and be more flexible and agile around about that. The alcohol and drug partnership's taken a similar approach, etc. But probably other people in other areas would use different language around that as well. So that's been our rationale for it, Dorothy. But I'm not sure. I could Google whether there's a clear definition, but that's how I would explain it to you.
No, that's helpful, Catherine. So a framework would always be accompanied by a delivery plan or an action plan, or, you know, right, okay, that makes sense to me. Thank you. Thanks, Catherine.
Thanks for asking that, Dorothy. I think that helped a lot of us. Martin, would you like to come in?
Thanks, Chair. And first of all, I'd like to welcome you on behalf of carers to Dundee, and I hope we have some good working time together over the next however long you're going to be here.
Thank you. Looking forward to it.
To Matthew, a couple of things on this report. The first thing I was going through was trying to find it on my computer here. Sorry. Yeah, it was 7.2, the membership of your group. That is quite a wide group, but I've noticed that there's no involvement. And I know what Dorothy mentioned, that your colleague is going to be joining her at her bladder session, but I was thinking, is there not an idea for some sort of permanent membership on that group of someone representing the elder, either Dundee Pensions Forum or Age Concerned Dundee or some other organisation, to get that aspect into the conversation, and also someone from the carer side of things as well, because from a personal position myself, I noticed that I've had to deal with a number of people just walking in the street who have had trips because of the conditions on the underground, and helping them. It's been a rather interesting experience in that respect. The other thing I was wanting to raise is, in terms of the data, do we have any data related to the environment and how that affects slip, trips and falls? Because I know from where I am at the moment here up in St Mary's, the condition of the external paths and drop points and such is degrading at such a rate that it is now becoming quite a serious issue. I know, because again, from personal experiences, I've done falls, which is rather unsettling when you're pushing a wheelchair and you collapse because the ground is so uneven, and having to call out to your careful person to tell them to stop the wheelchair from sliding down the hill. A bit concerned there, but I just wanted to know if there's any data that's available about the environmental impact on slip, trips and falls.
Great, thanks, Martin. Your first point, absolutely. I think that's an oversight on the part of myself as the chair and the group, and I will take that back to the group and we'll discuss that. And I think it will only enhance and strengthen the group, so we'll absolutely look at that. In terms of the environment, we do have data. I was just having a quick look, but I couldn't find it there straight away. In terms of falls in homes and outside and the different sort of areas, the falls outside are very low. I think it might have been 8%, but I'll have to check that figure and come back. For quite some time, because we have been aware that people have got concerns about lighting and pavements, we have been asking through the falls group very specific questions about locations to see if there were any areas that were causing concerns. There's no definitive evidence to support that at this stage, but because that's something that we know that people are concerned about, Masha, who's meeting with Dorothy's group, has been doing some work meeting with groups and asking those sort of questions, just so that we can understand because the data that we get and the referrals we get, of course, are people that have fallen and gone to ED or SAS and then been referred through to us. They can self-refer, but a lot don't. So maybe people are tripping but not making it to those areas. So we will continue to explore that and continue to look at that. We're aware that it is something that's raised, but right now it isn't something that we've got definitive evidence to actually point people in the right direction to take some proactive work on that.
Okay, thanks very much, Matthew.
Thank you.
Okay. Catherine, were you going to come in there, or she's gone
It
again?
was Matthew's
Oh, he's
covered
covered it.
most of it. We have had Lindsay Webster, my colleague, has had conversations with our colleague in, I think it'd be City Dev, within the council, to look at whether we can even match up some of our data about falls locations and their data about complaints and insurance claims around pavement conditions, etc. But it's just not possible because of the limitations of the data to be able to do it at that level. It would require a lot of manual work to look through records and identify locations that we just don't have the resources to be able to manage to do that at scale anyway. So in terms of scale work, we've kind of pursued that and understood it's not possible. But obviously Matthew's group are looking at it in a slightly more detailed way as well.
Okay, that's handy, Catherine. Thanks for that. Liz, would you like to come in? You're next.
Well, hi Matthew. I just want to say thank you very much for this report. I found it really interesting and informative, and it's not often I can say that about reports. And a lot of my issues have been raised and answered already. But I unfortunately spent quite a long time in hospital recently and saw lots and lots of evidence of just how things could be improved in terms of maintaining people's mobility and function. And it's not appropriate to discuss this here, I don't think, but could I feed that back to you? Would that be helpful? And I suppose just a personal story, although I stayed very, very active when I was in hospital, I still, when I left hospital, struggled to climb a flight of stairs. And that was astonishing, just how quickly that could happen to somebody who at the time was in my early 60s. I was relatively fit. Over the course of a few weeks, I lost that ability. So that life curve about how quickly you can lose functional ability, I think is really important. So yeah, if I could feed that back to you, that would be grand. And I suppose I was going to mention grit bins. I know you've talked about people don't often fall outside, and I find that quite interesting. So perhaps it's not as relevant as I thought it was, but recently we were told our grit bins would not be filled by Dundee City Council. They would no longer met the criteria. So where I stay, we were in the fortunate position of being able to afford to fill these bins ourselves. It wasn't a huge cost. It was, I think, £45 per bin. But I thought if you compare that to what might happen if somebody falls, has to have an ambulance trip to hospital and perhaps a fracture, then it just pales into insignificance. So there's that thing about that whole systems approach. And I don't underestimate how difficult that is, but that's just from my personal experience. And I wonder what other areas perhaps Dundee City Council are no longer providing grit to and what impact that would have upon them. So thank you very much, very interesting. And if I could feed back some comments too, I presume it's you, Matthew?
Yeah, please, Liz, if you come straight back to me, we can either do that via Teams or Meet or via email, whatever's easiest for you, no problem at all.
That'd be grand, thank you.
And you think your comment there about not being able to do the stairs and what have you, it's absolutely right. The figure for your functional reserve, it reduces by something like 5% per day when you're in hospital. So it's no surprise, but it's worrying that people weren't working with you to preserve that and grow that in hospital and out west. We have been starting to do some work with some volunteer groups about some of this, but yeah, it's a big problem. But getting your perspective on that would be really useful. Thank you.
And do you know what? I knew that figure, but it was still a shock. The reality was still quite different. And I was somebody who did remain very active. I walked around that ward, but still, yeah, that was quite shocking.
Absolutely.
Thank you.
Thank you.
Thank you, Liz. It's good to see you looking so well. And I hope you're feeling better now. Can I just ask, who would pick up the issue about the bins, the grit bins? Is that something that Catherine could maybe go away and look at and just get back to Liz on?
Yeah, we can speak with the colleagues and other services around that.
It's just to get a sense of what the position is. we're coming out of winter, but I think it might be important for next winter to get some clarity on that. So thank you very much. Lizzie, you want to come back in, or is that you clear? Okay, thank you very much. Ken, last but not least here.
Thank you. Yeah, Liz, I'm sorry to hear about the grip bin situation. I would suggest that anyone that finds themselves in that position where the council has withdrawn the refilling of grip bins should contact their local councillor and get them to ask questions of senior officers of why that's the case. And glad to see you looking so well, as was just said. My question really is going right back to the start. The point that Donald made really chimed with me about why we are an outlier and why we are an outlier to such a significant extent in terms of the number of falls. And then later Emma said that this was perhaps due to an issue with coding. And I've heard this before, not only in relation to falls, but also in relation to other kind of areas that are not fully explained in terms of our performance. And the answer has been that it's because we may code it differently from the rest of Scotland. I'm just wondering how we resolve this issue, because we need to kind of be in sync with how the rest of Scotland, or maybe they need to be in sync with us. Who knows? But it's just kind of frustrating, because it's a maybe this is what it is and maybe it isn't, and I would kind of just like a definitive answer to that, and to get this sorted out once and for all. Not having a go at you, Emma, not your fault, but yeah. I'm sure Emma's not taking it personally. Do you want to come back in, Emma?
Yeah, I mean, this is the challenge that you have with any routine, what we describe as routine data. That's data that's recorded as a part of a system. And there will be anomalies, Scotland, UK, internationally. So when we are using data, there is data that we have kind of greater reliance on. So for example, birth data, death data, that's data that there's no ambiguity about. Even actually, though, when you're looking at cause of death data, there is, again, a degree of variability that's introduced, because you're relying, unless you're conducting a post-mortem on every death, you are relying on clinical judgment given the circumstances that are around you. So I hear the frustrations in terms of why can't we standardise data across all parameters. What that would require is for every presenting condition or situation to have a very stipulated case definition. So, for example, a fall is defined as such and such. Confusion is defined as such and such. Delirium is so actually it then becomes incredibly unworkable. So what is really important when you're kind of thinking about the data that we're using is where the strengths are of it. And for us, it will be about charting change and improvement, because I don't think there will be a significant change in how the clinicians are coding falls. But it's not, I have to be really, really clear, it's not isolated to falls, it's not isolated to NHS Tayside, it's just a function of the data and how we interpret. It doesn't mean that the data is useless. It's really, really, really important, and particularly those longitudinal trends, and to look at where we can make improvements. But it's that bit of critical appraisal as to why. Why is it higher, and why is it flagging up? Coding could be an element of it, or it could be that we genuinely are seeing that increase for environmental reasons, for X, Y, and Z. It's part of the critical appraisal of data, and it's, yeah, there will never be a satisfactory answer, Ken, unless we invest millions of pounds and effort across the whole system, Scotland, UK wide, etc. Matthew, is there anything else that you want to add on that?
No, I don't think so. I mean, I suppose part of the work that we're doing is trying to understand the data as best we can, and understanding some of the journeys that the patients have as they move through the system. And if we can answer definitively that question about how we're supporting people, you know, those perhaps with more social reasons for being in ED overnight and then returned home in a safer way, then that will be really useful. But that's some of the work that we want to do. So it won't change anything with regard to the coding, but we'll be able to give us a definitive response to the fact that perhaps our numbers are high, but we're providing a higher quality level of service too. It would be my hope, but obviously we'll have to look at the data to see that.
Okay, thank you both.
Thanks for that answer. It's something that in my, sitting here in my own head seems quite simple. Why can't we just get this sorted? It should be easy, but clearly it's not that easy. Emma, and thanks for your response.
I mean, I should say that for other medical conditions like pneumonia, it is more standardised. Does that make sense? Myocardial infarction, there's a very clear diagnosis. As I reflected, falls is more a symptom of what has happened, so that there is more variability with that as a kind of diagnosis.
Okay, thank you. Dorothy, do you want to come back in?
Just a final comment. Thank you, Emma. That was a useful explanation. I have often have a problem with data, especially at the PAC when we've got loads and loads and loads of charts and diagrams, and I'm looking forward, Dave, to a development session for the Integration Joint Board members, the non-health professional people on the board like me, to help me to understand data better. I think it's really important, for people like me, local elected councillors, and who are here to make decisions, and based on data that was presented, that we do have a better understanding. So I'm hoping you'll be able to slot that into a future development session for IJB members to help us understand. Thank you.
Good point, well made, Dorothy. I'm sure Dave's taken that on board.
It's already one of the ones we're planning, so thanks
Brilliant.
for that.
Okay, and thanks, Dorothy, for raising that. Okay, any other points of clarity or anything we want to ask Matthew? We can let him go. Okay, so I'll just summarise this. The recommendations were that we note the contents of this report and the analysis of falls related to hospital admissions. We note the current model for prevention and rehabilitation and how this links with the wider socio-economic situation. And we note the development of the Tayside Falls Prevention and Falls Management Framework. Are we all happy with that? Okay. Thank you very much, Matthew, for your input. That's okay. We'll move on to the next one then, Arlene.
Okay, thanks. That takes us on to item 8, which is the 2024-25 budget development update, and you're asked to agree the recommendations.
I'm assuming, Dave, that you're going to take us through this one.
Assuming correctly, Beth. So thanks.
Okay,
thanks
I'll hand over to you.
So this report, I can appreciate not every member here today has been able to attend the kind of budget development sessions, but it kind of builds on a lot of the discussions that we've had at those kind of sessions, and kind of really gives us the most up-to-date position as we have it just now in terms of the sort of development of our budget for 24-25. So kind of a few points to kind of note within there. So following the publication of the announcement of the Scottish Government's budget, which is still not completely finalised, it's working its way through Parliament at the moment, but more or less we know what's going to kind of happen in terms of that budget, subject to kind of few kind of things that may change. So we know what the kind of the financial settlements are for both the local authority side and for NHS board. The council side of things, kind of reflecting that back, has been in the report. It's kind of been to council committee, so local authority kind of members will be kind of clear of what that is. But overall, there was a kind of deficit for the local authority, a reduction in kind of government funding as well, and the council's kind of working its way through that kind of process to set a budget, which will be done next Thursday. So from an IJB perspective, we have made assumptions on the basis of the conversations I've had with Director of Finance of the Council around what the budget offer from the Council will be, but at the moment that's still subject to get approval at the Council budget setting meeting next week. So More or less from that side of things, from the council perspective, it's a flat cash settlement for us for 24-25, apart from the funding passover from Scottish Government to support the 23-24 pay award, which was provided to the local authority. So there's about £1 million coming across for that. Furthermore, the council will commit to passing over the funding announced by Scottish Government to support the implementation of the £12 an hour minimum payment for adult social care workers and for our external care providers, and also our share of the funding for to uplift the free personal nursing care rates, which is a kind of legal requirement for us to do so. So council has indicated that money will be passed in full over to ourselves, so we can implement the sort of national policies on that basis. So that's been factored into our kind of budget projections for next year. In relation to the health budget, we have been used to, ourselves and health boards have been used to kind of having an uplift provided each year. For 24-25, there is a flat cash for the health boards in terms of the 24-25 costs. There are some additional funding kind of allocations going in to cover pay for 23-24, which will be kind of baselined, and that we'll kind of get our sort of kind of allocations of that. There was also some other funding provided for kind of to support sustainability of health boards in 23-24 that is kind of going to be mainstreamed. We will not receive any kind of allocation of that resource. So it is in effect a kind of flat cash settlement list apart from the pay award for 23-24 from a health perspective. Unusually, Scottish Government have taken the approach in terms of pay for 24-25 to not put any funding uplift in the baseline for NHS budgets at this stage. And what they have said is they'll commit to funding the kind of whatever the pay award is during the year. So if that's not agreed till say September, then the funding allocation to support the pay is assumed to be fully funded and would kind of flow through at that stage. So from our perspective, we've taken both the kind of potential cost increase of the pay award from a health perspective and any potential income out of the equation in terms of our figures. What we've kind of done, again, reported kind of previously at our previous IJB, is look at the range of cost pressures that we expect to experience over the next financial year. So that includes some of the kind of current year pressures, particularly around demand and kind of social care, and the additional investment we've made there to kind of keep the system moving, if you like. Also recognising further demand increases expected over the course of next year as well for both adults and older people, and a range of sort of kind of cost increases that we're kind of likely to face, primarily around kind of pay on the local authority side. So in effect, we won't have any additional funding to support the pay awards, whatever that's agreed. So it's in effect, because of efficiency, we need to try and find within our overall resource. And also that recognition that in setting the current year's budget, we used a number of non-recurring elements, including reserves, to balance the situation. So we need to kind of put that back in as a, we resolved that in 23-24, we need to kind of put that back into 24-25. So the culmination of all those, we continue to kind of work through because of there was a number of things have gone the right way for us and a number of things have gone the wrong way for us. We're really kind of facing a shortfall that's very similar to what reported back to you in December before the announcement. So we're around about a £10.7 million gap for the IJB, which is the biggest gap that we've faced since the inception of the IJB itself. So kind of quite a challenge ahead of us to try and kind of to kind of balance off the budget for next year. We will continue to kind of work through those cost pressures, refining them as best we can. So we've got, by the time we get to our budget setting meeting at the end of March, that we've got as as accurate a picture as we possibly can at this stage of what those pressures might be, but also in terms of the funding and what funding will be kind of provided to us to support the situation. With the gap of 10.7 million, we will also be presenting a range of kind of actions and interventions and savings to kind of balance off the budget for next year. And again, we will have the opportunity to get and discuss those at our kind of next development session. But in terms of the formal IJB meeting, they will be presented to the IJB alongside the sort of budget proposal for 24-25 at the end of next month, I should say. So that's the kind of updated positions where we are. As ever, kind of happy to take any questions or observations on this.
Okay, comments, questions, clarity, anyone? Oh, I think you're going to get off with this, Dave. No.
Don't say that.
I think that's, I have to say, oh, Dorothy, come in.
Just to say, I've been, I think, at 2 development sessions that Dave's organised previously, and they're very useful, and, you know, good discussion going on there about mitigations and use of reserves, but we can only do that once. So I think that's why I don't have any questions on this today, because Dave's very helpful, had these development sessions for us already, and more to come.
You've just taken the words right out of my mouth, Dorothy. I was just about to say when you came in there, I think that's a testament to the fact that Dave has been working very closely with us, all as members of the IJB, and taking us through this whole process. So I think that's a reflection very positively on yourself, Dave, around how you're steering us through these stormy waters. So we have this for recommendations are that we note the content of this report, including the potential implications to the delegated budget of the impact of the Scottish Government's draft budget on Dundee City Council and NHS financial settlements, as set out in section 4.2 of the report. That we note the provision of additional specific funding from the Scottish Government to support health and social care integration, as set out in sections 424 and 426 of this report. And it remits to the Chief Officer to present a proposed budget for 24-25 for consideration by the IJB at its meeting on the 27th of March. And good luck with that, Dave. So thank you very much. Okay, well, and we'll move on to the next one, Arlene.
Councillor Lynn's got his hand raised.
Oh, sorry, Ken. I turned away too quickly there.
It's okay. It's not in relation to the budget. I'll just hold fire until we have our next budget development session. It's occurred to me that this may be Donald's last meeting. Is that correct? No?
I think he's back in March.
Okay.
I wouldn't miss the budget IJB for the world. I'll be there.
Okay, thank you. Thanks, Ken. You've got to keep an eye on coming and going, haven't you?
You do.
Oh. Right, okay, Arlene, can you take us on to the next one, please?
Yeah, thanks. That takes us on to item 9, which is the financial monitoring position as at December 2023, and you're asked to agree the recommendations.
Okay, Dave, back to you, I'm assuming.
So I'm going to pass this one on to Christine.
Christine's
going to lead us through this one just now. So pass on.
I'm very lucky to get the privilege of this one. So obviously most of you know that we bring our regular financial reporting to every meeting. This latest set of numbers is based on the actual data and actual numbers up to the end of December. So 9 months of actual and 3 months of projected to the end of this financial year. The latest projected operational overspend position is now showing at £4.78 million. Still an awful lot of money, but actually an improvement on the previous set of numbers that we had brought to you. So the previous reported overspend was actually £6.6 million. So we have seen some improvements, and I'll take you through a couple of the reasons for that. Just within the recommendation section, it notes that, or previously we were noting, because of the extent of the overspend, would be required to be bringing a financial recovery plan. So in section 4.7, some of the actions that have been taken by officers in regard to that financial recovery plan are noted in there. And there's also the recommendation in 2.3 in terms of asking the IJB to approve release of £1.7 million of earmarked reserves to support the Tayside-wide inpatient mental health position, which is further detailed in 4.3.9. So that section summarises some of the current year financial risk sharing arrangements that have been subject to continuous negotiation and discussion with NHS Tayside and our Angus and Perth and Kinross IJB and council colleagues through this year. Ongoing conversations in terms of developing the plan for 24-25 and beyond that as well. I'll let Dave come in at the end, as he's been extensively involved in these negotiations and conversations, so I'm sure he may want to pop in just at the end in terms of any further comment, as these negotiations are continuing, these conversations are continuing. In terms of improvements from the last report, we've seen an improvement in our GP prescribing position, which is very welcome. Our projected position for this year was £1.5 million overspend, which we identified in last year's financial plan and set aside some funding to offset that. The actual position, or the projected overspend, the latest data is actually coming in only about £600,000 overspend, so quite a substantial improvement. And more data, and the new data collection system that's been introduced nationally for the pharmacy payment system is now being brought much more up to date. So we're getting much more confident that the information that we're getting is reliable and is reasonable. So those numbers are giving us a bit more confidence in terms of the current year and then future look as well. And we, as Dave mentioned through the budget setting, Dundee City Council have confirmed release of additional funding towards supporting the council pay award, additional costs that we experienced and we saw this year. So our previous report had assumed no funding from the council, and it was a cost pressure straight to the IJB's bottom line. But we've received about £1 million of funding from the council, so that obviously drops straight into directly into the improvement in the bottom line. Many of the other overspending and underspending reasons through the report are detailed in the different sections of the report, and the numbers are detailed in the appendices. But many of the reasons remain the same in terms of recruitment and retention challenges, reliance on supplementary staffing, significant demand on the care at home packages. So many of these reasons are still there. Many actions are continuing to be taken in terms of mitigating that and addressing that, and that's obviously things that we've discussed in more detail through the budget development sessions as we look towards next year and resolving some of these issues. And the only other thing I just want to highlight, and it's just an addition into this current report, is in section 4.6 in the reserves section, we've added a column just as an indicative closing reserves for this financial year, where we think that may get to based on the current spend patterns and the current utilisation of reserves. So it's just that, obviously it's still indicative until we go through the full year end process and close this out. But that's just to give yourself some assurance in terms of where we think our year end reserves will be as at this stage. And then obviously then that helps us in terms of illustrating where sort of budget setting and financial situation for next year may get to. So I don't know if there's any points or questions that I want to raise, or if Dave wants to jump in just now in terms of anything further to add or that I've missed.
No, thanks, Chrissy. I think the only thing I just want to kind of go back to, as you'd said, was around the inpatient mental health kind of situation. So, you know, we had kind of referenced this in previous reports that there was kind of ongoing discussion around the financial risk here around inpatient mental health. It is an unusual kind of situation in terms of our setup, and whereby there's a separation out between the strategic kind of responsibility that the IJB has and the operational delivery that in terms of kind of through the Health and Social Care Partnership, and therefore under the Chief Officer's kind of role in this regard. So because there's that kind of separation, it's not been kind of quite as easy to kind of navigate through the integration scheme and the legislation around, you know, the kind of responsibility, which is why we've had for a number of months kind of conversations at kind of chief execs level, including chief execs of the local authorities, because of course there's an implication potentially with that from a local authority perspective of this. And that has kind of really centred around coming to a kind of mutually satisfactory conclusion to how the kind of cost pressure within that service can be supported. The challenge around it is because there's a combination between operational issues that have kind of caused the overspend, and also from our perspective the things like kind of delayed discharges and, you know, the kind of the number of beds that we are kind of utilising within the service. So it's not quite a kind of straightforward kind of in terms of whose responsibility is it anyway to kind of to support, which is why we've come to this position. Just kind of very recently, I think it was 2 weeks ago, I think it was last week, we had a further meeting and agreed to kind of split the costs of or the share of the overspend in a kind of on a four-way basis between the 3 IJBs and the health boards. What we're kind of looking to do and what the ask is of the IJB is so we can almost like protect our bottom line position that we've kind of looked at, is to kind of utilise funding that sits within our reserves that were given to us by NHS Tayside about 2 or 3 years ago, to kind of support any sort of kind of other kind of financial pressures in the system, with kind of particularly looking at how we kind of shift the balance of care. By using that money this year, it kind of helps kind of maintain some of our kind of other reserves, or kind of more free reserves, which will help us as kind of next year as we kind of go through the kind of the investment that would potentially required under the mental health kind of new sort of strategic kind of planning side of things. So we're trying to stabilise the financial position this year to kind of support us for next year and going forward around that. We may have a potential ask of another 125,000, which we can absorb within our position, because there is a bit of a residual amount that's not been identified yet. That again, we're committed to share kind of basically kind of a straight four-way basis on that. We are kind of looking at how the service can pull back spend over the next kind of, well, at that point it was 2 months, to kind of pull that spend down. So the ask is of the IJB to kind of approve the release of that reserve to kind of protect our bottom line position. We haven't got any, we've never brought any sort of kind of proposals forward for that £1.6 million. It's kind of sat as a something that we can use if we require it, and my suggestion is this is something that we should use just now for those purposes. So hope that's kind of clear on that, but Kristen says happy to take any comments or questions on anything on the report.
Okay, thank you, Dave. Any questions, points of clarity for either Christine or Dave? Dorothy?
You know how I love reserves, Dave. So that 1.6, that's part of committed reserve. So we couldn't be looking at using any of that to balance our budget in any case, could we? So that's committed reserves.
We set that aside as an earmarked reserve when the money came in. We says so that's what we would use it for, whichever purpose that we wanted to do it as an IJB, but it was around, you know, probably kind of more around what we can do around shifting the balance of care or kind of other investments on that basis. So that's so you're right. It's not kind of sitting as a free reserve as that we've kind of used for other things in the past.
Thank you.
Okay. Any other points? Can I just say I'm really impressed about the prescribing? I think it's such a huge problem across Tayside, particularly in the other IJB that I'm involved with. So, you know, I think it's really impressive that you've got some kind of grip on that. So just wanted to note that. Okay. Well, the recommendations that we have are that we note the content of this report, including the overall projected financial position for delegated services for the 23-24 financial year end, as at 31st of December 23, as outlined in appendices 1, 2 and 3 of the report. We note the steps to continue to be taken by officers to consider options and opportunities to improve the financial position during the remainder of 23-24 as part of the financial recovery plan process as outlined in section 4.7 of the report. And we are asked to approve the release of earmarked reserves totalling 1.6 million to support the overall financial position for inpatient mental health services in Tayside, as outlined in section 4.3.9 of this report. Are we happy to note these and approve the funding? Okay, that's great. Thank you very much. Okay, Arlene, do you want to take us on to the next section?
Yep, so the last item is the IJB attendances for 2023, which is submitted for information.
Okay, thank you. If there's any queries, Arlene's the lady to go to. And that just leaves us to go on to the last item. Arlene, is the next date?
Yep, so the date of the next meeting is the 27th of March at 10 AM, which is the budget meeting.
Okay, that's lovely. Well, thank you very much. That was pretty painless for me. I hope it was okay for you guys as well. I'll look forward to seeing you on the 27th of March. And I think Ken and Dave, you were going to stay on till we try and get a date together. If you could stay on for 5 minutes.
Yeah, sure. Yep.
Yep. Thank you.
Okay, thanks everyone.